Hi, everybody. My name is Mike Cantor, and I am happy to be with you today to moderate this panel on medical nutrition therapy, aka MNT, and nutritional counseling, a holistic approach for patient health. We're going to take a minute or two before we get started to let people join. During this time, if people want to go in the chat and say who you are and where you're from, please feel free to do that, and we'll get started in just a minute. Nice to see people jumping in from around the country. So please feel free to put in your name, where you're dialing in from. For those of you watching on video delay, it's too late, but hopefully you'll join us live next time. We'll get started in just a few seconds. All right. So welcome, everyone. Really excited to have you with us today for this very interesting panel discussion about medical nutrition therapy. Before we jump into the content, let me take care of a little bit of housekeeping. First, we're really here as part of the Aeroflow Advantage Be in the Flow webinar series. This is an ongoing series of events where we bring together experts with interesting expertise in relevant areas of healthcare. And we invite health plan colleagues from around the country to join us for these webinars and on delay. And also really encourage everyone to use the chat, submit questions through the chat or Q&A so that we can answer your questions and make this really as interactive as possible. Last webinar we had was in Sleeptember. It was about women's health and women's sleep health in particular, and looking at understanding how gender differences, particularly in sleep apnea, make a difference in how women are diagnosed, how they're treated, and how health plans even have designed benefits to cover people with sleep apnea. Highly encourage everyone to check that out if you haven't done so already. Today's panelists with us, outstanding group. I'm Mike Cantor. I'm the Chief Medical Advisor for Aeroflow Health, geriatrician, and a lawyer by background. A lot of experience working with health plans, health systems, and the organizations that support both of those. With me today is Sophie Lauver, who is a registered dietitian and a board-certified health and wellness coach who works for Aeroflow Health. She has many initials after her name, which are a testament to her expertise and experience. And I'm really looking forward to what she has to say about medical nutrition therapy. Also with us today, Ryan Bullock, Chief Strategy Officer for Aeroflow Health, a seasoned healthcare industry executive, deep expertise in durable medical equipment in particular, and an understanding and helping patients and their families manage chronic illnesses like diabetes, and very supportive of creating an organization that brings not just technology, but services and people to support the patients who are using those technologies. And last, but certainly not least, Dr. Bob Gabbay is with us. He's an associate professor of medicine, Harvard Medical School, longtime colleague, and also until recently was the chief medical officer of the American Diabetes Association, a well-known, very experienced endocrinologist and diabetologist. Really happy to have him here with us. And I think this panel is going to be really great in sharing with all of us what is medical nutrition therapy and what is it doing for us and how does it work in the age of GLP-1s? Lots of great things to talk about today. So let's jump into it. And we really do want to make this a holistic approach and would love to have your questions. So for those of you who are joining us live, please use the chat to put questions and we'll get to that and the questions and answers after the panel discussion. So first, what is this medical nutrition therapy or MNT? And how does it help patients? And how good are we at taking advantage of what actually is a very positive way of helping people manage chronic illness? Bob, let me ask you first. What is medical nutrition therapy and how good are we using it?
Yeah, it's an important question, and maybe I'll just start from the perspective of diabetes and obesity. and frame this a little bit. So, if you just think about the numbers, uh, uh, in so many ways, diabetes is the poster child for the value of medical nutrition therapy. We know that what people eat have such a profound influence on their diabetes, how well they do, and the complications they can have. Uh, just sharing some numbers, 38 million people with diabetes, 97 million with pre-diabetes, and therefore at high risk. And recent data published says that 3/4 of Americans either living with being overweight or obesity. So huge numbers. Diabetes, 1 out of 4 healthcare dollars spent. So a profoundly important area. And medical nutrition therapy is really effective in improving A1C, that measure of average glucose, that is the predictor of complications of diabetes, eye disease, kidney failure, amputations, etc. And so we know that it can lower A1C dramatically. Uh, we know that the costs associated with diabetes and obesity are mitigated by medical nutrition therapy. Staggering statistic I just saw that in 10 years, obesity is expected to cost $9.1 trillion. That's with a T. So profoundly important. Um, and so medical nutrition therapy is really providing the guidance, the tools, the problem solving around eating and how it affects one's health. And it's crucially important in diabetes, but not just diabetes. In literally most chronic diseases, what we eat makes such a difference.
Is it true that you are what you eat?
In many ways, it is. Certainly, our health is dictated by what we eat.
Very, very interesting. And by the way, what's the relationship between the statistics you gave, 120 million people roughly in the United States who have prediabetes or diabetes, and then a huge percentage of people who are overweight or obese? These things related?
Very much so. So, obesity is what is fueling the increase in diabetes, particularly for type 2 diabetes, which is more than 90% of the people living with diabetes. So if we could get to the root cause, which is largely obesity, we can prevent the development of diabetes. And in fact, uh, for people with prediabetes, we know from large randomized controlled trials that medical nutrition therapy can lower the risk of developing diabetes by 60%, and that's the diabetes prevention program.
Wow. So lots of people with prediabetes at risk, 30 million or so, I think you said, who could be helped. 60% of them would do well and avoid becoming diabetic. And once that horse has left the barn, and you have diabetes, you can go back to having normal blood sugar, but you always have diabetes, right? Which is actually disturbance not just of blood sugar, but also of fat and protein metabolism, right?
Very true. And the reason we'll talk about people being in remission, because they still have diabetes and are still at risk for complications, even if their glucose levels are normal and therefore, have a good A1C. So it's important that they continue to get screened for complications of diabetes.
Got it. There are some populations, aren't there, who get diabetes, type 2 diabetes, but it's not related to weight. So it's important to watch what you eat, even if you're at normal weight, because that can also affect your risk of diabetes. Is that
Very
right?
true. Very true. And, one of the things that we'll talk about a little bit when we get into the new medications that have helped with obesity, um, is that it's just being at a normal weight, but essentially you could imagine, and I have patients that say, "Wow, I can eat anything I want now because I no longer have obesity." We know that's not good for you, and there's lots of evidence that junk food, ultra processed foods, high sugar containing foods are really not healthy.
Interesting. Let's move on to this next topic. So what is this medical nutrition therapy, and what's the role of the dietitian in this? Sophie, maybe you can help us understand. You are a dietitian, a card-carrying member of the food police. So maybe you can explain sort of what is this and why is it so hard to get people to actually do this?
Yeah, so I think I'll start first by talking a little bit more about what MNT is. I think Dr. Gabe kind of primed us for the need for, the services we provide, but it's essentially a therapeutic dietary approach to preventing or managing chronic diseases. So, it involves meeting with a registered dietitian, either individually or in a group setting, to collaboratively assess a patient's nutritional status. So the dietitian is assigning a nutrition diagnosis. We are coming up with a personalized nutrition intervention based on the patient's specific needs, their medical history, their labs, their finances, their lifestyle. And we ultimately are conducting regular follow-ups to monitor the patient and evaluate whether our goals are being achieved and troubleshooting any challenges that are coming up to ensure that the patient can be successful with this plan. So, for conditions like type 2 diabetes that we're talking about, we are looking to improve glycemic control. We're reducing the risk of developing cardiovascular disease. So we're looking at cholesterol and high blood pressure. We're looking at reducing weight if somebody's overweight or obese. So that's kind of the starting point of what we're looking to do. In terms of our role as the food police, I think a lot of patients think that they don't need to see a dietitian because they know what they need to do already and they just need to do it. But I think the role of dietitians in facilitating behavior change is lesser known. And our role in not just assigning what is recommended, but helping the patient to get there is where we often provide the most value.
What's
And
interesting
I'll
here
also
is
say, like, in terms of the food police recommendation, it's rare that one of our dietitians will see a patient and say, you can't eat this. There's room for every food. We truly believe that all foods fit. And we have been trained, through school and our continuing education that we are not there to shame patients for what they eat. We are a very accepting profession now. Hasn't always been that way, but now we are. And we really encourage patients to eat foods they enjoy in moderation and in ways where they can fit them into an overall plan to reach their health goals.
one of the interesting things is it's really about behavior change, right? So can you help me not only understand what I should eat and how I should, how often I should have certain kinds of food, maybe not avoid, but have some in lesser quantities compared to others. So what's the difference between a dietitian, and maybe even start there, dietitian versus nutritionist versus RDE, registered dietetic, RDE,
Or
expert,
DN, yeah.
yeah, yes, a registered dietitian, and then a health coach. Like, how does this fit together in terms of different things we call these people? Because I think even the terminology for what you
Yeah.
do is a little confusing.
Yeah, absolutely. It is confusing. So I think the most important distinction is between nutritionist and registered dietitian. There is no regulation around the term nutritionist. So anybody off the street, and this is what happens sometimes, can call themselves a nutritionist and recommend that somebody eats, whatever it is. Whereas a registered dietitian has to meet a very rigorous set of educational standards in order to pursue that credential. There are continuing education requirements every, so many years in order to maintain that credential. So there's standards around that profession. Health coaching is kind of another profession that's exploding now. The challenge is that there are not standards around that term either. But there are certifying bodies that are kind of coming up as the gold standard. So we have the NBHWC, which is really coming out as a very reputable coaching certification. And so health coaches cannot prescribe, diagnose, come up with, they can't provide medical nutrition therapy that is tailored recommendations for a specific disease state. Where they can have value is helping a patient in the how piece. So the dietitian can perform the assessment, prescribe the plan, and the health coach can be a key player in the team to help the patient get to that plan and adhere to that plan. So I think, as long as we're looking at health coaches with appropriate education, the team should be made up of a registered dietitian with appropriate education and a health coach to see the patient regularly and make sure that they are aware of how to continuously meet their goals.
Got it. So very, very helpful. One person you didn't mention on the team is the physician, and you could also substitute nurse practitioner or physician assistant in terms of people who can prescribe or order medical nutrition therapy. Bob, you're a doctor. What's the problem with getting doctors to engage with nutritionists, I should say, or registered dietitians and health coaches?
Yeah, it's a good question. We know that these services are woefully underutilized. We know they're effective, and they're woefully underutilized. And I think that the problem is at a couple of levels. One, making the recommendation. Many physicians and other healthcare professionals don't really, still think of the food police idea that needs to be erased. Uh, the way I view these individuals is we know that nutrition is one size does not fit all. And that's probably the biggest difference. It used to be that, well, I could just give my patient a handout of what they should
Mhm.
eat. Well, we know that doesn't work. If someone gave you a sheet of paper and said, eat this for the rest of your life, I mean, come on, that's never going to be effective. But that was what happened for so long. Um, I think the idea around behavior change is worth sort of expanding on, because what these individuals do is help to problem solve. Start with, what do you like to eat? What are the cultural factors around what you eat, so that it isn't one size fits all? And then let's design something that can work for you. And that's so much more effective than the old-fashioned, here's a handout and eat this
Mm.
diet.
And I think
Yeah, I think,
also interestingly, I'm sorry to jump in, Mike, is
no,
that
go
okay?
ahead,
Do we have a second?
please.
Is that oftentimes that can really damage the relationship if the provider is, quickly prescribing this dietary plan to the patient without having the time, as a lot of doctors don't, to really figure out what's going to work for the patient. So, there's a real rise in obesity stigma. Providers for many years were handing patients handouts on weight loss or low carb diets, or, whatever the fad of the day was. And the patients felt very targeted because they felt like, well, my doctor doesn't know that I've been trying really hard to lose weight. And they just handed me this form saying I'm overweight and I need to lose weight. So the dietitian can really figure out, with the patient's help, what's going to work for them and take the time to create that plan.
Agreed. And I think going back to something you said before, that's important, is it isn't just about weight. It's not just, it's about diabetes, and it's not even if it's diabetes, it's also about blood pressure. It's about cholesterol. It's about really the whole, what are you eating that's helpful and healthy for you, not just are you avoiding the foods that are bad. And I know that in terms of problem solving, I think that's also critically important, because there's this Thanksgiving holiday that's coming up in the next couple of weeks, and that's our national eating holiday, and we try and eat as much as we can and complain about it. So I think that's a great example of where nutritionists and dietitians and health coaches can say, okay, you're going to be at Thanksgiving dinner, you're going to be confronted with this situation. Let's figure out together how you're going to get through that. And if you have a
Yeah,
big meal on Thanksgiving, what's the rest of the weekend look like, right? It's not over in one day.
exactly. And physicians right now in this country are not receiving, adequate nutrition education either. And I think that's worth calling out. I think the status is like less than 25 hours of nutrition education are provided across 4 years for many physicians, and less than 20% of medical schools have even one course that's required for, young doctors in nutrition. And a lot of times the recommendation is just talk to your doctor about these dietary changes, but they also might not be the best ones to be asking. So it's worth knowing.
I agree. And I think it's just another argument for we need team-based models of care, because
Exactly.
physicians
Yep.
do not, and providers more broadly, just do not have that expertise. And we don't have the time. If we have the expertise, we often don't have the time to solve these problems and to say, hey,
Right.
text me, ping me, chat with me through the portal, whatever it takes when you're confronted with that beautiful donut, you're thinking about how to get around that, right? So that's where I think doctors and providers can really take advantage of the skill sets of dietitians and health coaches.
Yeah,
Um,
absolutely.
oops.
And I would add that that's the message that one gives to the patient about why to go for MNT is really important,
Mm,
and emphasizing it's not the food police. And I know you know what you need to do, but they're going to help you figure out how to make that happen. What are the
right.
challenges, what are the barriers, and then how to get around them. And there
Yeah.
are all sorts of little great tips that they can give. I think when I frame it in that way, people are much more willing to engage.
Mhm. Yeah.
Totally agree. So one of the interesting things about Aeroflow is not only does it provide the durable medical equipment, it also provides services to help people optimize the use of that equipment. And one area where Aeroflow does a lot of work now is with continuous glucose monitors, working with people with diabetes. They're trying to better manage their blood sugar and overall health. Sophie, you've really helped to create this new program in Aeroflow. Can you say a bit more about what is it and how it works and what you're seeing in terms of early results?
Yeah, absolutely. So we are currently offering individual and group sessions with registered dietitians, completely all via telehealth. And so we are offering classes on diabetes nutrition, heart healthy nutrition. We have a class now about holiday nutrition and how to kind of eat and be successful during this challenging time of year. We're working with patients with diabetes on weight loss. And I think for many patients, we're talking about similar dietary interventions. So we're looking at increasing fiber-rich foods, eating more whole foods, reducing added sugars, reducing sodium intake, how to meal plan successfully, how to be more active, um, eating balanced meals. And our ultimate goal is to empower patients to make informed choices. So the dietitian is working with the patient to figure out what's going to work for them. Patients come away from our sessions with specific goals they need to be working on that feel achievable before the follow-up session. And the dietitians are providing any resources the patients need in order to be successful. So whether that's recipes, shopping lists, I don't know, we've done, brainstorming with patients for recipe ideas. We've looked up kid-friendly recipes if that's a challenge in the household. So it's really like having your kind of personalized guide to help you navigate the challenges you've been facing with your nutrition. And we even now excitingly have an open format question and answer class for patients to ask anything that they've been wondering relating to their nutrition or their CGM use. And that's been wonderful too. So patients kind of can come and drive the conversation based on their needs.
And it looks like the people have been pretty, I think, pleasantly surprised in some cases in terms of how helpful this has turned out to be. Like you see the quote on the slide where Monica was saying, "This is my first time experience with a dietitian. She's very professional and patient at the same time. She listened to my concerns very carefully, planned a nutrition plan for me to help me manage my diabetes during my pregnancy. I'm more confident now. The best part is she's always reachable if I have any concerns or questions regarding my diabetes or diet." I mean, that is an amazing service. Why wouldn't everybody want to have somebody could call or text or whatever and say, "Hey, what should I do?" So congratulations on getting that launched. Ryan,
Thanks.
you haven't said anything yet, so it's your turn. Tell us about how this is going from more of an administrative perspective. Like, what is the program? Are you seeing a lot of people? Have you gotten much interest, or has it been tough to convince people to use this?
No, I think, and one thing maybe to touch on Sophie real quick, not to do a spoiler alert, and I know we're not quite there, but there's a lot of buzz internally that we're all super excited about is having a live cooking class as a part of that, because I think it's not just providing those recipes and shopping list and trying to get those behavioral changes, but actually how do you visually see this in action, and what does that look like? And so really excited. I know it might be a little premature to announce that, but really excited to see what that is going to turn into.
Absolutely. That like how piece again is really important. Not just saying, eat more of this, buy more of this, but at the end of the day, showing patients what to do with it when it comes into their kitchen. So yeah, I'm glad you mentioned that.
Yeah. And I guess to that point, we are seeing increased just search volume from typical Google, Facebook, and the ways that we connect with members, and inquiries even within the patient population that we serve. We do have a fairly large diabetes population, and they're seeking to understand a little further what is that connection between the data that I'm receiving and the food that I just intook, and how does that impact my glucose levels and overall diabetes care. And I think because of that, wanting to understand that connection, we're seeing more inquiries around that. And I think the other thing that was mentioned earlier is that there's not a prescribed one for all. And I think people are beginning to understand that, and wanting to seek what will work for me that may not be just a blanket prescription of, go eat healthy, less sugar, et cetera. But going back to our customer care team, I think in the patients that we currently service, what we're seeing is in those interactions with our customer care team, who's contacting the member on a monthly or quarterly basis to talk to them about their CGM, getting the resupply that they need for their CGM, ensuring that they're still compliant in using that device, and getting the information back out of it. In those interactions and conversations, we're able to identify opportunities to begin to introduce medical nutrition therapy to those members, and get them into a group class. And I think Sophie might be able to speak to this a little better, but in the group class setting, it puts them maybe at ease and among peers that are going through and experiencing health challenges with like people, and knowing they're not alone in that. Sophie, I see you're unmuted. I don't know if you have anything to add there.
No, I think you're exactly right. One of the benefits of the group class setting is that patients are in that supportive environment. And the dietitian can take a little bit of a step back and really encourage participants to support each other and share stories and share what's worked for them in certain situations, because that's often a lot more valuable than somebody who may not understand that patient experience providing suggestions and recommendations. So we often see, a higher satisfaction rate with group classes and a higher rate of adherence when the recommendations aren't coming, directly from the dietitian.
Yeah.
Oh, interesting.
Along those lines too, I think Dr. Cantor, you mentioned this is creating that somewhat of that interdisciplinary team, and that's really what we found in Aeroflow Diabetes and the other divisions in the company, is that we can really play a role in that interdisciplinary team. We're in constant communication in a lot of cases, more so than the physician or other members on that would be a part of that team, and looping in folks like Sophie with registered dietitians that can help kind of uncover those areas, and being a support system to refer that patient back to the physician when they need to go back there, or other healthcare professionals along those ways. And so I think that's some of the ways that we have found, going back to the original part of getting patients introduced to medical nutrition therapy.
I think it's really important to provide the support for the patient, to learn, the person with diabetes, learning how to use a new technology with a continuous glucose monitor, CGM. I've read in the past that up to 40% of patients stopped using the continuous glucose monitor within 6 months because it was too overwhelming, even though this is the best tool you can have in terms of blood sugar measurement, blood sugar management. Is it still that high? Ryan, I don't know what your numbers are in terms of, after 6 months, what percentage of people who start with the CGM that they're getting from Aeroflow are still on that versus other parts of other people who may not be getting that level of support that Aeroflow provides?
You're absolutely right there. And we do see that. There's our customer care team will receive patients that complain of alarm fatigue, or the inability to get a good reading out of the sensor. And so we're able to get those members with a diabetes specialist who can help them understand, exactly where to put the sensor, based on their anatomy and physical makeup, to try to help overcome those. And I think it's very similar to medical nutrition therapy, is that we've got to create those habits, the healthy habits of using the tool, make sure that we can find a way to overcome those barriers that they're running into. And we're really hypersensitive and focused on achieving that with the members.
Fantastic. So all this sounds great, but it's got to be really expensive, right? And who pays for this? How is it covered? How hard is it for people to get approvals? Do they need an approval? I mean, how does this work, Ryan?
Yeah, I think as outlined here on the screen, it's becoming more and more normalized, I guess, if you will. Medicare covers 3 hours of medical nutrition therapy in the first year, and 2 hours annually thereafter. There was a stat on one of the previous slides where it mentioned that 1 in 4 patients will adhere to a nutrition plan if there's proper follow-up. And the 3 hours may be limiting in order to achieve that. Obviously, Sophie and Dr. Gabay can speak to that as clinicians and being able to get patients to make those proper changes. And so I do think there's still a lot of work in that area to be able to expand the coverage and see the outcome and impact. As Dr. Gabay mentioned earlier, the food that we consume and the activities that we participate in ultimately will be the decision and deciding factor in the outcomes that are achieved. And that's something that we want to peel the layer back on with the work that we're doing is being able to measure those outcomes.
Great.
I think the challenge too is that like Medicare is covering those 3 hours or 2 hours. That's for patients with diabetes or kidney disease. They're not covering a wide array of diagnoses right now. They're not covering prediabetes. They're not covering preventative, services. And that's very limiting when we recognize the importance of prevention and chronic disease. So worth mentioning.
Bob, what's your take on that? I mean, given that your work as sort of a public health, not just for individual patients with diabetes, of course, but more broadly looking at diabetes related policies, this is great for people with diabetes, but prediabetes isn't covered. I mean, what's happening to kind of get the powers that be to rethink this?
Yeah, there's a lot of advocacy work, and when I was at the American Diabetes Association, we're really fighting for a particular program that's evidence-based, that relies heavily on medical nutrition therapy, the Diabetes Prevention Program. It's covered by Medicare, but not by many other payers. And the battle has been really for coverage for that. And it's such a cost-effective intervention for people with many chronic diseases. You could see here the complexity of coverage depending on what line of insurance one has, and I think this is also turns out as a barrier for clinicians in terms of referral because they don't know whether it'll be covered or not, and some more uniform coverage would be helpful. I think the last item on this slide, I think, provides the promise that there's recognition that there really is value and that most health plans are thinking about how to invest further into MNT.
Yeah, that's a really good thing. And I guess the question is sort of what does the ideal look like and who's out there today that's actually providing this more ideal coverage? Ryan, do you have thoughts about this?
Yeah, as we mentioned here on the screen, Aetna and United Healthcare were 2 that we thought were worth including and calling out that are doing a good job. For United Healthcare, it's needing an elevated BMI in order to qualify, and they have no maximum visits. And then Aetna, they're able to qualify through the Healthy Diet and Counseling program with only dietary counseling and surveillance diagnosis on the claim to be able to cover those. Aetna does have a max benefit of 10 individual or group visits. So there's a slight limitation there, but I think more time is available than what we saw earlier with Medicare.
And it's a case that some of these can be renewed, right, Sophie? So if you see a patient and that patient isn't making as much progress, you have the opportunities under Medicare, I think, to recertify and say, hey, Mike still needs help with this. I'm going to keep working with him for a little bit longer.
Correct. They allow for a second referral in the same calendar year if the patient experiences a change in status, isn't meeting treatment goals, et cetera, where the patient could potentially get unlimited sessions with the registered dietitian covered.
Great. Bob, thoughts about this? What does the future look like for these benefits?
Yeah, I'm hopeful that there will be better coverage. I could tell you from the clinician side, it'd be lovely if I knew exactly what people's coverage were on an individual basis and therefore could refer. I think the other thing that is becoming more clear is you know, frequent touches are particularly effective. So, when you think about any kind of behavior change, there's learning what you need to do, how to address some of the barriers, but then over time, you need sort of regular check-ins and tweaks of the plan, and those don't have to be long visits; they could be shorter visits, and providing this virtually is obviously way more convenient for many people.
Yeah, I'm not going to tangent, but I think the emphasis on face-to-face or basically synchronous, live discussions is misplaced in a world where text messaging and portal messaging and emails are very effective ways of reaching out to people or for them to solve problems in real time. I don't need to have a face-to-face with you to ask, I'm here at this restaurant, I'm faced with this, this question. Can you just tell me which one I should choose? Or what's the difference in terms of if I choose this one or that one? And people can get back to you that quickly now. And I think changing the payment mechanism to be more of an episodic payment rather than a visit-driven or class-driven payment might be really helpful. We've seen this in other value-based care models where it's really you get paid for the care you provide rather than just a specific visit. That tends to be more helpful for people with chronic illness.
I think
so let's go on.
Here is that preventative focus. And I know the U.S. Preventative Service Task Force has, they've done a lot of work, and there's a lot of recommendations to health plans that use evidence-based informed recommendations around the benefits of medical nutrition therapy. And I think making this benefit as a preventative benefit and removing that cost share to encourage more use. Because as Dr. Gabay had mentioned that the food has and obesity, I guess, has a large impact on other chronic diseases, and making that more widely available, I think, is very important in getting a wider adoption of the benefit.
Yeah, I think they say 80% of our longevity is based on lifestyle, and nutrition is a critical component of that, along with exercise and sleep. And so some of us are born with certain genes, others are not, but we can always decide what do we eat. And most of us can. There are other constraints, of course, that impact people, but there's clearly an opportunity to impact health broadly, not just illness and disease, but to keep people healthy and not ever get to having diabetes or whatever.
Yeah, they say genetics loads the gun and diet and lifestyle pulls the trigger.
I like that. I hadn't heard that before. I gotta use that.
Yeah.
So let's move on to another really interesting area. So the GLP-1 medicines, I think literally twice a week, I'm reading about how great they are for something else. Most recently, it was pancreatic cancer, showing for the risks, a reduction of risk of pancreatic cancer for people with diabetes who had taken GLP-1s, although initial concern it was worse. Now we're seeing data that's better. The other day, utilization and hospitalization by people who are taking GLP-1s for diabetes, fewer hospitalizations, fewer shorter hospitalizations when they are hospitalized. These medicines are really powerful. And clearly reduce body weight. They really improve outcomes in that area. The people who use it together with medical nutrition therapy have even better results. And as expensive as these medications are now, there's a lot of concern about what happens when more people need to take them and how we're going to be able to afford it. So obviously, anything that can help people succeed even more than they already do would be fantastic. What is the role of medical nutrition therapy in supporting treatment outcomes? And what's the current state of the evidence, Bob?
Well, one thing that people are often unaware of is that most of the studies, the clinical trials that, led to the approval of these medications and provided the evidence included medical nutrition therapy as part of the intervention. So,
Hmm.
if you look at the gap between real world evidence and what we're seeing in the field using these medications, we're not seeing quite the same weight loss as we did in those trials. And the difference is the lack of MNT. I think the other important area is around side effects. So, a really astounding percentage of people, about half of people, stop these medications within the first year. Side effects are certainly part of that. Not only are there the side effects of nausea, vomiting that can, in many cases, be managed with appropriate sort of eating behaviors. Uh, but also, one area of concern of these medicines is the loss of lean muscle mass, and ensuring proper protein intake can really reduce that muscle loss. And we know that lean muscle mass is critically important, particularly as people age and tend to lose muscle mass.
Yeah, I think there's a lot of concern. I'm a geriatrician, obviously, a lot of concern using these medicines in older adults because already the shift between lean muscle mass and fat tissue, that shift occurs with aging, and then you give someone a medicine where it apparently accelerates that. Then you have to pump up the protein in the diet. That's not lean protein is actually very hard to come by, it turns out, in terms of ease of access, and then supplements. Well, which supplement? I mean, it gets more
Mm.
complicated than it might appear, which is why we need the registered dietitians to help us with this and the health coaches to help us keep us on track. Um, but is there a role here, Sophie, for getting people off of these medicines and supporting them with MNT instead? We heard from Bob that clearly MNT helps with GLP-1's impact and effectiveness, but is there evidence showing that you can actually get people off these medicines, which are now prescribed for life? Is there a way to do that?
So I think right now the limited evidence is showing that, discontinuing these therapies can lead to weight returning to baseline. It's suggested that we slowly, wean patients off these medications. Of course, that doesn't always happen. And that's happening concurrently with like a 2 to 3 month behavioral program so that we can mitigate weight regain. So MNT, I think, can provide a valuable role for, a patient not gaining back all the weight if they do have to discontinue a therapy. And if the patient is on the medication and that's, they're seeing success, kind of like Bob teased, we can help with side effect management. So, if patients are experiencing nausea, vomiting, other GI issues, there's a lot of dietary changes and tips and tricks that can help with that. And then, in terms of preservation of lean muscle mass, ensuring the patient's eating adequate protein, ensuring that they're not becoming malnourished as they are able to eat a lot less than they used to, and making sure that their meals are still nutritionally adequate given their very limited intake on these drugs.
Very, very helpful.
One other thing I might just
Okay.
point out is
Yeah.
for most people, most of the time, the conversation has been about the quantity of food in terms of weight loss, and the good news is that these medications are pretty good at people reducing the amount that they eat, and now we have an opportunity to really focus on the quality of what they eat, and we know the quality of what you eat is super important in terms of cardiovascular disease, diabetes, leading causes of death, cancer risk, etc. Becomes a lot easier for people to start focusing on that because the concern is that people can, you know, keep a normal weight and eat nothing but junk food. And I, and we know that's not good, and that's where I think MNT can have an increased role is guiding the quality of what you eat.
Agreed. And we have some great questions to get to from our audience participants. Before we jump into those, one last question for each of you. when you think about the future of medical nutrition therapy and its impact, are you optimistic, pessimistic? What gives you hope, and what are you worried about? And why don't we start with Sophie?
Yeah, it's a good question. I mean, I think my biggest concern is the underutilization and the impression of dietitians out in the world today. I think a lot of patients don't realize that they can access a registered dietitian through their insurance benefits. A lot of people think that they can't afford to see a dietitian, and they don't even entertain the idea. Of course, there's still challenges with inadequate insurance coverage. If a patient has Medicare but doesn't have a qualifying diagnosis, that can be really challenging. And I think at the same time, you know, the patients that are seeing dietitians, we're seeing really impressive outcomes. There are many more telehealth companies coming out in this day and age, making dietitians more accessible, you know, helping with the marketing piece that patients can see dietitians with their insurance. The role of food in disease prevention and management is becoming more widely known. There's healthier products on the stores these days, you know, integrating nutrition into processed foods, and kind of allowing that convenience aspect of healthy eating, which I think is important. So, you know, despite the challenges, I do feel really hopeful for the future that, you know, our service is becoming more utilized. Our dietitians are becoming more accessible, and we just need to continue to get the word out.
Great, Brian.
Yeah, I think overall, I'm really hopeful. As I mentioned earlier, excited about the live cooking class that we're working on rolling out, and I think that brings a lot of hope for the future with personalizing nutrition to the individual and making meaningful impact and changes to their overall health outcomes. I think one of the things that we've seen work in some other areas and disciplines is what I would encourage health plans to consider here is creating a stakeholder meeting and pulling in clinicians and operators that are working directly with members to discuss what their current policy is and how it's working, and then what are some of those kind of frontline items that we should consider in the next policy revision or as that policy is being developed, and getting that frontline engagement and input.
Fantastic. Bob?
I would say I'm optimistic. I think we're over these last couple of years with particularly with, the sort of conversations around GLP-1, people are thinking about nutrition and obesity in a way that they had not before, and it's front and center. And so I think that's a positive. I think programs like this help make people more aware that it's this underutilized resource. And I also agree that the access through digital health programs, I think, really allows it to reach people in a way that it couldn't before, and that's that accelerated over the pandemic. But we're still seeing that as policymakers start covering that more effectively, which I think we see that happening. I think we'll see even greater benefits and access to a valuable service.
And we need to have the
Agreed.
continuation of telehealth benefits, long into the future as we look at, Medicare continuing their telehealth policies. That's vital to what we do. So I think about that a lot.
I think that's right. And I think the technologies are communication technologies like telehealth, but also, like I said, figuring out a way to cover the time spent
Yeah.
responding to text messages and portal messages and emails, and also using technology to help people track. Already, people have trackers that they can use for weight, they can use it for calories, they can use it for micronutrients, macronutrients, they can use it for checking in with their health coach. It's really important to help people access those technologies in a way that works for them. Some people like wearables, some people don't, but there are lots and lots of technology that are available to help people stay on track, get on track actually, and then stay on track once they're there nutritionally, and combined with exercise and other things you want to measure as well. We do have some interesting questions from our audience. I'd like to jump into those. Bob, this first one's for you. So if someone has gestational diabetes, like we talked about how when you go from prediabetes to diabetes, now you have type 2 diabetes, even if your blood sugar is normal, everything else is fine, you still have diabetes. Is that true for gestational as well? Like, do pregnant women who develop diabetes, are they considered diabetic for life?
It's a great question. So they're very much at high risk. So gestational diabetes is typically diagnosed in the third trimester of pregnancy in someone that did not have diabetes prior. Uh, and many will revert to normal blood glucose after delivery, but a half of those women over the next decade will develop diabetes. So they're really at high risk. And again, interventions to prevent that from happening can be really effective.
The medical nutrition therapy is important even postpartum, not just for
Right.
supporting breastfeeding, but also beyond that to reduce the risk of diabetes and people who've had gestational diabetes. Very interesting. Question for you, Sophie. So the majority of people with type 2 diabetes, when they start working with nutrition programs, are they there because their doctors or providers twisted their arms? Are they there with a positive outlook? What's your sense in terms of people showing up? Are they there like excited and positive, or like, oh no, here I go, I doubt I'm going to stick with this? How do people show up?
Yeah, so for where we are in our program right now, the majority of our patients are entering the program willingly. They're interested in the idea of making changes. They're in a place where they feel like they can change, and they're interested in the benefits of, proper glycemic control. Of course, there's always a handful of patients who are kind of in the wrong place at the wrong time, and that's okay. But I would say most people are excited about the promise of making dietary changes and building this relationship with a new dietitian.
Excellent. Ryan, you're seeing a lot of
One thing,
people come. Oh, go ahead, Bob.
I'm sorry. I was just going to add, we're coming up to two like interesting periods that can be leveraged. One, the holidays where people tend to struggle, and I think that's a particularly valuable time for MNT to be engaged. But also, people's readiness to change around New Year's
Yeah.
is sky high, and that's a great time to leverage engaging people and having a conversation with someone who may not have been willing before to engage, but now they're ready.
Interesting. Yeah. So the behavioral change models of pre-contemplator, contemplator, making change, sustaining still work. And so catching people in those
Yeah.
pre-contemplator, contemplator where they're thinking, oh, maybe this year will be different, but I will pay for my gym membership but actually show up after January. Those kinds of things I think are definitely the right windows. And Ryan, I'm just curious, when you see comments on the website, you're watching the traffic as it comes through. Are people showing up and voting with their feet in terms of signing up for classes, or a lot of people saying this just isn't for me? What's your sense?
No, I think the sense is they're curious. As you mentioned, and I think the other element too is that we've established a layer of trust with the member because we are providing their continuous glucose monitor to them, and it's a peer that they've built a relationship with our customer care team, and through that, when they make that introduction, it's a little bit easier handoff than sometimes getting that prescribed by a physician. And so I think that introduction is uh, is carrying that curiosity on into actually activating and engaging in signing up for a class.
Excellent.
Yeah.
Here's another question for you, Bob. I think there's a lot of different places where medical nutrition therapy can be beneficial, not just for diabetes, high blood pressure, cardiovascular disease. This person's asking, are there positive results from medical nutrition therapy for people with autoimmune diseases, for lupus or for other sort of autoimmune problems?
Yeah, interesting. I think there's some data there. Certainly, many people will describe feeling better, and particularly with chronic diseases like many autoimmune diseases, that can be an important goal. And then, of course, type 1 diabetes, which is an autoimmune disease, there's tons of data on the value of medical nutrition therapy.
Fantastic. Sophie, what's your experience in sort of the more autoimmune area instead of the cardiovascular or metabolic disorders?
Yeah, no, I agree with Bob. There's there's more research to be done in this area. I think anecdotally, a lot of patients experience benefits. You know, dietitians can help with elimination diets or figuring out food triggers or, you know, recommending various supplements. It's an area where more research needs to be done. There's some testing that's currently conducted that I don't think is, you know, the highest standard of evidence-based. But I think the benefit is that a lot of patients with autoimmune diseases have experienced really tough side effects and challenges, and they haven't had a partner to kind of troubleshoot alongside them. So the dietitian helping, you know, figure out or prescribing like a food journaling regimen and figuring out time eating regimens that work, you know, specific foods where they notice triggers for their symptoms. I think that can be really helpful, and relieving some anxiety around the, you know, what they're experiencing. And then of course, like helping to reduce inflammation through, you know, nutritious diets can be very valuable. But I think there's probably more research out there relating to MNT and its value with cardiovascular challenges.
Got it. And our time is coming to an end, but one last question. It's about genetics. There's increasing information about epigenetics and lifestyle changes to influence genes. Do you think that we'll be doing genetic testing to help guide medical nutrition therapy in the future? Like, do you see the day when we'll use it to decide who should get medical nutrition therapy, or a day when the first thing the dietitian does is look at their genetic profile to decide how to recommend certain kinds of food? Bob, you want to take that one first? And Sophie, love to hear your follow-up.
Yeah, this is an interesting one. Uh, you know, I think it's really getting into precision nutrition, and I think there could be a role once the ability to test is inexpensive enough. Um, what we do know is that, you know, with various diets, and you know, the great examples are low carbohydrate and low fat diets. If you take large populations and compare them, you really see no difference. That said, any individual within that, there's a big variation in response, and being able to understand why some respond one way or another. A thing I typically ask people is, have you ever lost weight before, and what was the strategy that worked? That's a cheap version of individualizing therapy. But yeah, I see a future where precision nutrition could be valuable.
Yeah,
Sophie?
I agree. It's definitely the way of the future. I think for right now, it probably sidetracks people a little bit more than I'd like. I think focusing more on the lifestyle change is the effective piece, regardless of the genetic piece. You know, you may be more predisposed to high cholesterol or high blood pressure based on family history. But we know that, you know, proper diet and lifestyle changes can at least mitigate some of those consequences. So I'm eager to see what the future holds in terms of more personalized nutrition. But I think for right now, we know what works for a lot of people. And it's really a small subset in the scheme of things that are not seeing results from our common interventions.
Yeah, I think you're right. I think we are going to see a day when genetic testing is inexpensive enough, and we also know more about which genes influence who's better off on a low carb or high carb or low fat or high fat. When that day comes, that'll be important. I think also the microbiome is something that we're still learning a lot about.
Yeah.
That I think will be really interesting to see, and the interplay between the microbiome and our genetics and so many different omics, you know, proteomics, and all these other things. It's going to be very interesting. Metabolomics, being able to think through and make recommendations that really are that specific for individuals. So I know we're coming up to the end of our time together. So a couple of housekeeping things for me to take care of. And before I close, I just want to thank each of our panelists, Ryan, Sophie, and Bob, for what was an excellent discussion, very enjoyable. And as usual, the time flew by. But these are such interesting topics, and I look forward to more discussions about this in the future. Just so everyone knows, we will be sharing a link to this very soon, so you can watch this on recording. We'll also, if you'd like to learn more about the webinars and be kept up to date for future events, subscribe to our newsletter. This third one, please take the survey at the end of the webinar. We're planning for 2025. Would really like to have input from everyone who participated today, to let us know what you think you want to hear more of and less of, for that matter, and what we can do to make these really valuable for you. And then feel free to follow Aeroflow Health on social media, wherever you get your social media information, Instagram, et cetera, et cetera. So thank you so much for joining us. Really appreciate it. Thanks again to our panelists, and I wish everyone a very happy, healthy, and nutritious day.
Mhm.